discussion because I mean, we often debate this same philosophy, and then when we combined high frequency ventilation with other therapies that we think are beneficial, like kangaroo care or skin to skin, it becomes much more difficult to manage those patients, at least with our high frequency system, which is a more stiff circuit and a little bit more difficult than conventional ventilation. And so the other things that we lose come up some of our assessment skills, and so it's hard to assess breath sound, for example, of someone who's on a high frequency ventilation, because all you hear is the pitter patter, and you don't really know, is that a wheeze, is that crackles, is there anything else going on in that particular child, and so then you're totally reliant on chest x-rays and gas exchange, and I've been telling you guys, I think yesterday, that I think gas exchange is a really late sign of pulmonary dysfunction, and a lot of times you'll see drops in compliance and those types of things that you can measure easily on conventional ventilation. So you know your tidal volumes are dropping for the same amount of pressure, or your peak inspiratory pressures are going up if you're in volume ventilation, those types of things. You get better, to me, indicators than a surprise blood gas. A lot of times when you're on high frequency, you get surprise blood gases, and I don't like surprises, because that means that they haven't been ventilating for a while by the time we get blood gases, because we just don't get them that frequently anymore, and so you have to use additional monitoring to do that. And so the other thing is that for you guys, resources aren't unlimited, I guess I should say, and so even in the U.S. And so if we were to start putting all of our micro preemies on high frequency, we would quickly use up all of our high frequency ventilators and we wouldn't have any for rescue. And so how do you debate that as well? How do you manage that?
You've got a problem, you are stuck with your high frequency ventilation machine. We do not have this machine in Egypt, and we do use machines which are done for conventional high frequency at the same time. I'm pro the theory behind the words of Dr. Muhammad. I think high frequency ventilation is better than conventional ventilation in recruiting the lung. So if you start by opening the lung from very early in the disease and give surfactant, it will be much easier afterwards to shift to convention or to wean directly, and you are avoiding, you are going to use what I call the opportunity window, at the phase where the patient is improving, and you don't want the patient to be stuck to the ventilator. It is much easier to pick this window in high frequency with the recruiting maneuver than on conventional ventilation. What do you think about this?
So our practice, when I was in a pre-me NICU for 14 years before I went up to Chopper. We don't have the premature babies anymore, and we had quite a few that were under that 1,000 grams mark, and we went straight to high frequency. But we didn't make the decision right away. We would say, when we're going up to delivery room, if the baby's not breathing and they need to stay intubated, we're going to go to high frequency, and we're going to give them surfactant. If they are really, really vigorous and they seem pretty spunky, we'll intubate, surf them, extubate them, depending on where they fell in that age range. And in some kids, we would put on CPAP. Usually, when we were somewhere around that 28 to 30 week mark, it depended on which physician was up there with us to say whether they wanted to intubate and give them surfactant, or if they wanted to leave them on CPAP and wait it out. But that was our practice too. And oftentimes, they weren't on high frequency. It was definitely less than a week. It was, a couple days or so, get them stabilized out, and then we would extubate them to CPAP the same way we would have. And literally, whichever respiratory therapist was admitting that baby, you pretty much stood by the bedside for the first couple of hours and did nothing but wean. So we stood there, we were constantly weaning so that we could get them on the lowest possible settings after surfactant. But that does take a lot of resources at that time, and we had a commitment to it in that unit, and everybody just kind of rallied around it and did what you had to do to take care of the rest of the babies. And we also, I guess because of the practice that we had there, I'm much more a fan of let's see what this individual baby needs for us to do, and we'll kind of, I don't want to say wing it because that sounds like we don't know what we're doing, but we'll flex from there, because instead of kind of one way or the other, we have to do this or we have to do that, we always kind of pick that middle ground. And that we would, if we were intubating them and giving them surfactant, we would do it right away, but we wouldn't do it in the delivery room. But we got it in within a half an hour, because our delivery rooms, especially if it was in a C-section, were very cold. And we were so worried about the cold stress on the babies that we quickly got them into the NICU, into their bed, and it was like a very structured, planned event. Everybody had their role, everybody did exactly what they needed to do, and oftentimes in their nice, new, comfy bed, in their environment that was quiet and warm and had humidity and everything that they needed, we had umbilical lines and they got surfactant and they were settled within a half an hour. And just having...
You just need to make your obstetricians uncomfortable and turn their speed up.
Oh my goodness. The first thing we would do when we walked in the room was check the temperature, and we literally had logs and constant conversations back and forth between the neonatology and the obstetricians, because we would walk in and immediately we agreed to a temperature, like a medium temperature. We'd walk in and immediately go turn it to that medium temperature because they had it down so cold. And you see everybody, like you can hear them huffing and their eyes are rolling, and you know everybody's uncomfortable with them. Like, this is what we agreed to. Stop pushing it.
So I guess I have similar experience to Natalie, is that we tend to use high frequency more as rescue. Now sometimes that rescue. That's what I interpreted. Winging it, you know, that means rescue. And typically it had to do with the assessment in the delivery room. So in other words, if they required a significant amount of oxygen to ventilate and pressures to ventilate, and we use significant, meaning above 25. So we had kind of these cutoffs that we would proactively put them straight on the oscillator when we got to the unit. If they didn't require that, then we tended to use conventional first and see how things go. But I told you my background is also, prophylactic surfactant is kind of their practice, and so they would initiate that in the delivery room, and then if they required more, then we'd be fine to put them straight onto the oscillator as soon as they got into the ICU. But other than that, it was a wait and see how well they did.
There's a couple of things also with this. We don't have some of your problems with the oscillators machine, because our machines here in Egypt doesn't have that rigid circuit. It's easily to be managed, and it's easy to nurse the patient and to care for him. And the other thing that you have sensor medics, and there is no monitoring on sensor medics at all. But most of the machines here in Egypt, we have some monitoring. It's not that good as conventional, but we can measure the tidal volume, so you can have a reflection on the mechanics of the lung and the compliance and something like this. So it's much easier our way.
Yeah, we wish we had that flexibility. It would be nice.
You can't be us in this.
I guess there's a couple other situations in which we would probably use high frequency that I can think back in my 20 years that we've used it proactively in those kids. Is parent or mothers that didn't get steroids, and so they were even more premature than probably what we're used to from a lung development perspective, or that they're likely to be septic and those types of things because of beta strep and some of those other options. We would actually do that. Full-term kids, if we switch kind of categories, kids that got lots of fluid because of fluid resuscitation due to sepsis or something like that, we would actually do that quite often. So as well, and so use the oscillator proactively. Any other comments or thoughts about high frequency? And we can move on to kind of another one.
There was a multi-center study in Italy comparing both in high-frequency ventilation, comparing an end strategy to do recruitment till they can lower the FiO2 to 25, and the other putting a cutoff limit of 30. And when they put a cutoff of 25, it resulted in much less stay on ventilator and much less bronchopulmonary space. I'm just wondering if you can, after doing your recruitment maneuver, decrease your FiO2 to 25%. What the indication of surfactant therapy?
Right. Yeah, I wouldn't give surfactant.
It would depend for us. So we would, if they were if they were 26 weeks, 27 weeks gestation or less, we would automatically give surfactant. And we would set our settings that we liked. Our mean airway pressure would go according to our x-ray. And we would wean at 21% before we would start touching our mean airway pressure, just to get that oxygen off as soon as possible. If they were on the ventilator and they were under 30 weeks, if we had to intubate them, we would give them surfactant. And we would just prophylactically give the surfactant because we were bad enough to be on the ventilator, so we would give it. And we were probably half of the physicians in that 30 to 28 week mark would just put them on CPAP and see what happens and then give the surfactant as rescue. Half of them would intubate, give surfactant, and extubate straight back to CPAP. And in fact, most of the time, we kept the CPAP in their nose. And we did it, intubate, gave the surfactant, just had one piece of tape on, held it in place, gave the surfactant as quickly as we could. And when we extubated, that pressure and CPAP pressure was still there in their nose. And then we didn't have to mess with it much at all. So,
The thing I would like to just comment about, the thing that hasn't been a direct comparison that I've seen is actually using that same type of recruitment strategy on conventional ventilation. In other words, using a high peak strategy, which is really what you're doing with high frequency a lot of times, is your mean airway pressure sometimes is 2 to 4 above what you were on conventional. And then we say it's the mode of ventilation is what worked. And I'm just not convinced that it is the mode. In other words, if I put them on 8 of peak or 10 of peak on conventional ventilation and used low tidal volumes, could have gotten by with just the same effect.
It's actually the pepophobia which push us to the...
No, and it's the pepophobia that the respiratory therapist blamed the neonatologist about because the oscillator's the answer to that. And so a lot of times we're supportive of it because really they just need a higher mean airway pressure. We don't really care how they get it. We just know that the patients get it. And if the neonatologists think that it's a safer mode of ventilation, then, albeit, and let it happen. The thing that I would like to caution you about is that stuff that the adult guys are seeing with high frequency ventilation is not improvement in outcomes, and because they do have a high PEEP strategy with conventional ventilation, and so they're not PEEP-ophobic, I guess I should say, and so I'm wondering if that's going to pan out in the future to that as well.
well, and I wonder if that's even a fair comparison, considering that the adults don't manage the oscillator the same way we do. They do this mean airway pressure FiO2 grid, like they do their PEEP FiO2 grid, and that's not how we manage oscillators in neonates and pediatrics. And there's no evidence. They have no evidence for that choice that they made to do it that way. And I, personally feel that that's probably one of the reasons why they might be failing. But they could even change the strategy and still have the same outcomes. We don't know.
Again, for the surfactant question that Dr. Sham asked, if after recruitment we are able to decrease FiO2 to 30 or 25, is there a place for surfactant? I think there is an experience from Anton Van Kamp. He is devising an index, which is he's calling the surfactant index or lung severity index, multiplying the FiO2 by the mean airway pressure. If he is still high mean airway pressure and he is able to go down by the FiO2, he is still giving surfactant. If the index is above 3, he is giving surfactant. Below 3, he is not giving surfactant. What do you think about this?
I think it's interesting, and it's a good, nice objective marker to have, but we need some more data. The researcher in me wants more data.
Well, I don't. To me, the definition of recruitability is a lot of times your chest X-ray and then your FiO2. And if they're not recruitable, then surfactant's applicable. If you're not giving it prophylactically, because you have a belief that they're surfactant deficient. If you have a belief that I'm not sure they're surfactant deficient, which is what you would use it for. In other words, if their FiO2 is low and their ventilator settings are low, I don't know if I give it because why? They've already basically said that they're open, their lung is open, and by definition they may not be as surfactant deficient as you think they are. So it's an interesting thought. I think the indexes probably certainly need it because I think our gut feeling is that if we ever had a child that was on a mean airway pressure of 12, for example, and an FiO2 of 25%, we'd probably still give surfactant. But we rarely would ever have someone on. We'd start weaning the mean airway pressure probably when we got below 40%, and start working that down because we want to head to extubation because we can give oxygen extubated. That's something we're fairly comfortable with, and so we're trying to move them towards getting the tube out entirely versus keeping the tube in and trying to treat something that we think they probably can do without. And so it's depends on what you think contributes to lung damage. And in our experience, it's the endotracheal tube. And if I can get that out as soon as possible, I'm going to do it. And so most people would not feel comfortable extubating someone from a mean airway pressure of 12, but we certainly would at 8 or less than 10 is typically what we would do. And if their FiO2 was probably below 30%, and so we may actually sacrifice that FiO2 to get the mean airway pressure down so that we can say, let's get them extubated, and not thinking about escalating therapy, which is giving surfactant and those types of things. But it's a very interesting concept. I think we know less about surfactant therapy nowadays than we did when it was first kind of designed and developed, because it was designed and developed for a patient that we don't see today, at least in the U.S. And we do have our fair share of mothers who do not get steroids before they deliver and those types of things, but that's becoming rarer and rarer nowadays. Is that if they're having any premature contractions, a lot of times they're given it. The emergency rooms are all, scheduled to do it. Their OBGYNs are all just programmed to do it a lot of times. And so to me, we have a baby that has a little bit more lung maturity than when the surfactant studies were originally designed and developed when we didn't give standardly prenatal steroids. So it seems like a lot of that data needs to be redone or studies need to be redone.
I want to ask about the heart, okay? We commonly see patients who have circulatory compromise, okay? How can you modify your recruitment maneuver using high frequency or high peak in a patient who have circulatory compromise, having a large PDA? How can you judge the ventilation, perfusion, matching? It's not only the lung which is affected, mostly the heart also, and they are working as one unit. So how can you modify your strategy with these patients?
So some of the things that we kind of take it on a case-by-case basis, and oftentimes we're doing what we can to help with their cardiac situation. If they're just shunting in their lungs because they have a large PDA, oftentimes doing a recruitment maneuver doesn't really affect it all that much. And then if we do it once and it doesn't, then we don't do it again. But what we'll do is really we'll watch them, and our recruitment maneuvers don't take very long. So if I was on conventional mechanical ventilation and my kid was a little bit collapsed, so we wanted to increase the PEEP and we wanted to do a recruitment maneuver, we would do the recruitment maneuver, come back down to a higher level of PEEP, so we only had to do a recruitment maneuver once. So we're not in the habit of doing recruitment maneuvers multiple times and keeping our PEEP at the same level of baseline. Because if, the thought process is if you need to do a recruitment maneuver to help recruit lung, then your baseline PEEP is not adequate. There are multiple different strategies depending on the machines that you have, and I don't know of one necessarily gold standard of how to determine what your optimal PEEP is. So everybody has their own theory and way that they like to do it, and however that is, trying to figure out what that optimal PEEP is for that infant. And if you're able to be at that optimal PEEP without having additional cardiac compromise, then great, and you just have to deal with whatever's causing the cardiac compromise for them. But if it's not a structural problem within the heart, especially right after birth, oftentimes they're fluid depleted. So we're doing multiple things all at one time. We're doing all the things we need to help their hemodynamic status as well as what we're doing to try to fix their lungs and keep them recruited and do what we need to do as well.
So I have a couple different ways that we do it often is that many times we'll do sustained inflation, and I agree with Natalie that a lot of times it's well tolerated despite patients that typically we kind of define it as on 2 pressors or more, or the equivalent of 2 pressors, and some of our folks use a pressor index based on the amount that they're actually getting and the strength of that particular pressor to say, I'm not sure they tolerate a recruitment maneuver. The thing that I think wisdom has taught us is that you can't ignore the lungs just because they have hypotension or those types of things. So you got to learn to deal with it. And so we typically do like 40 for 40, so 40 centimeters of water pressure for 40 seconds, whether it's on the oscillator or on conventional CPAP. And we look for a systolic drop of 20% or more in their blood pressure. And if that does happen, then we abort. And typically, we're only comfortable, in these patients, we typically have arc lines in anyway, that we're that concerned about their cardiovascular status, and so we have a beat by beat, basically, way of determining that. But we do still have patients that won't even tolerate that. And then we revert to a ramping strategy. And I think I was showing somebody yesterday it's a best compliance strategy. So you basically either put them in volume control or you put them in a pressure control, and you keep the delta the same. So let's just say 15 is the delta. You start off with a peak of 5 to 10, and you look for your tidal volumes. What are they with that delta of 15 on 10? And you keep climbing until you get kind of the best tidal volumes you see, and then you start seeing a decline in tidal volumes. And a lot of times by cycling the lungs still, a lot of times you can keep their blood pressure up and at least eliminate some CO2. Sometimes the 40 seconds is too long when you do a sustained inflation that they drop their cardiac output. So cycling the lung appears to still help a little bit with that. You still will get to points where they won't keep their blood pressure up, and then you basically have to stop and go down, but kind of bear with it. And often we'll have people standing by with fluid or even little, what we call spritzers of epinephrine to help keep their blood pressure up during that case, because we certainly don't want to collapse their right atrium, for example, and cause even more problems in these really sick kids. But in our experience, ignoring the de-recruitment only, just hurts you in the long run a lot of times. And so you should address it. You should take whatever measures necessary that you need to do to keep their blood pressure up a lot of times. Evaluating their fluid status is really important, and it's sometimes something, particularly in neonates, it's interesting because I work between both worlds. Most of our neonatologists run our neonates dry. I go to the PICU and they're all wet and fluid overloaded. And so I have to balance the two. And sometimes we do call our cardiology fellows to come in and assess our volume status to help us understand whether we should probably give volume to treat this hypotension or whether we should give more pressors in that status. Give both, yeah.
Give
That's
the
a lot
fluid
of
while you're
thinking
waiting for the
right
pressure to
there.
come.
Have both. And if one doesn't work, try the other. And so that's largely what we end up doing. I will say that the lung recruitment is something that people are starting to look at, and we're actually starting to study with CO2 elimination. So we measure volumetric CO2, so the amount of CO2 that comes out of the baby in 1 minute. And during this ramping, not only looking at for best compliance, but also looking for best CO2 clearance, because that may actually show you where the patient is best ventilated prior to over-distending. Because I worry that sometimes when we over-distend, which a lot of times you have to over-distend to recruit the anesthetic parts of the lung, you do more damage than you need to do. And so, because sometimes we over-distend so much and we stay there for a long period of time, that we do irreversible damage. And so now we got 2 diseases going on. We recruited the lung that we needed to help improve oxygenation, but now we actually tore some of the other lung, and now we have PIE and those types of things that can be deadly. And so
So actually in our NICU, we don't do 40 for 40 because people are a little afraid of that. So we'll do 30 for 30, or sometimes we'll do 30 for 20. So we'll modify that sustained inflation maneuver a little bit according to the baby and the comfort of the neonatologist. But we don't generally go up to 40 centimeters of water pressure on them, especially your smaller ones that are, preemies and they're only about a month or so old. We'll do a shorter one, but we at least make sure that we go up by 10. So if we're not going up by 10 centimeters of water pressure from where our PEEP is, it might not be, and there's no reasoning for that. It was arbitrary, but we go up by at least 10.
One thing that's vitally important that you have to think about is if you're on conventional, it's plateau pressure that opens the lung, it's PEEP that keeps it open. And this is something I think we forget. And so we were talking about some kids that yesterday that are poorly compliant. So you're having to use peak inspiratory pressures 30, 35, 40. And if they're on 35 and you do a 30 for 30, you're not going to really open their lung. Does that make sense? So you've got to go to 40 for 40. So you've got to modify that, go above, at least somehow above that. Otherwise, you're kind of not really recruiting the lung. And so just keep those things in mind, because sometimes we get into the policies of, oh, we do 30 for 30, that's our unit standard. Well, when most of the time your peak inspiratory pressure is 25, that works just fine. But in extreme cases where you have to use 35, 40, you're going to have to go higher than that to open the lung a lot of times. And so just keep that in mind. What other questions? Any other topics? Do we have like 5 minutes left? Or are we over?
Apart from the clinical part, I'd like to actually add the research, and we talked about yesterday, and some sort of interdisciplinary collaboration between using our data, maybe and yours.
Do you want me to talk about that? Is that what you're saying?
Yeah.
Yeah, sure.
Give an brainstorm.
Yeah. No, I'd love to brainstorm with you guys about that a little bit. Some of the things, like you guys have experiences that we don't have. And then we have experiences that you don't have. And I do full-time research, and so one of the things that I just was recalling that, for example, when I used to do a lot of asthma research, we could not find a steroid-naive child to study. So I had to go to another country to find steroid-naive children to study. Does that make sense? And so if you don't have nitric oxide, for example, and we do, for us to study the outcomes of another drug, or it'd be nice to have a collaboration which we could do that. Rena knows that I'm collecting a lot of streaming data from ventilators on compliance and resistance, elastance, like all these things that we just don't know about our patients. But my patient population, as I told you, typically gets prophylactic surfactant and get their mom gets steroids. And so you may have a different patient population in which I'd love to collect that data, because particularly all your ventilators, I've been looking at them, all have data ports that stream out data that no one's capturing. And if I can come up with a system that can capture it, use like the same Philips monitors that we use, and so that's all the unit. And I know I can get data out of those because I do it day in and day out a lot of times. And so those types of collaborations, I could be open to hear your thoughts as well on some of those things. For some of you guys that don't have high frequency at all, that's another thing. It's like, can we try a high peak strategy? In the U.S., it's really hard to change the standard or practice to experiment. Does that make sense? In other words, yeah. And so if you say, hey, what about doing 10 of 12 or 14 of peak on conventional and doing 3 per kilo tidal volumes, and using their patient population to study the effectiveness of that, and comparing it to another unit within Egypt that has high frequency that uses it proactively, that would be a lot of fun. And then we would use obviously the oscillator, because it would be hard for us to say we're not going to use the oscillator for rescue, because despite the evidence, it's become the standard practice. It would be really hard to consent parents and make them do those types of work. So that's something I'm very partnering with you guys about.
And then we also have some different, we have a couple different, what we call registries, where they're more observational research. One that I mentioned briefly is, it's called Neo for Neos, which is National Emergency Airway Registry, and 4 Neos is for the babies. And then we have 4 Kids, which is in the PICUs. And then there is the original, which is just NEAR, which is for adults. And we already have NICUs in Canada and Japan that are collecting data, and we're able to compare. And then through the PICU, we have PICUs in Singapore, Japan, Canada, and the Netherlands that are collecting data. So we're able to compare what happens from different countries, because there's different strategies, there's different practice levels, there's also different training levels of providers that do intubation to help to determine should there be a change in practice. For us, one of the things that we're looking at closely in our NICU, as I'd mentioned prior, is the standard use of paralytics during intubation, because it isn't happening, and we saw definitely a change in the adverse events for the infant. And then we're looking at what are those long-term outcomes. What does that mean? Does it matter if we did chest compressions for under a minute? If everybody was right there and we did it and everything, is there a long-term outcome? And we're looking at that data, but it would be great to, and that's a paper form that's filled out and then put in through an online. It's less experimental and somewhat easier to do, but you can get some good data to then make some quality interventions afterwards of changing practice and then see how that improves care, which we've been able to do in our PICU population because we started there sooner, that we've been able to reduce the amount of adverse events in our PICU population and nationally in the United States with the care bundle that we implemented to help improve care.
I want to ask about something you mentioned about changing practice as regarding suctioning the biggest child and not suctioning the biggest child. We know that this is a new guidelines, but do you think that is functioning? Because we are afraid and we are somewhat reluctant to practice it. And then after that you start to use surfactant to remove the meconium. What do you think about that?
Yeah, it's a great question, because habits are hard to change, and practices are hard to change, as you know, and that's something that I think we're forced with as well. Even as the older we practice, it's harder and harder, it seems like, for us to change. So I think we have to, as a profession, we have to be better at that, at changing with the data. And for all the good that I think I've done over the years from intubating and sucking out meconium and feeling really good that I actually cleared the airway and actually tidying the baby up and basically giving it to mom because of our intervention, and that child not having to go to the ICU. There were a lot of others in which I'm aware that actually caused them to go into a pulmonary hypertension crisis by intubating them and suctioning them out and de-recruiting them, and they were just a little bit depressed, and I didn't suction out anything below the pores, and so I think, to me, my experience has been about probably 50-50 with kids that I'm not sure I benefited them by intubating them, suctioning them out, and delaying basically resuscitation, even 30 seconds or 40 seconds if you're really good, may have been too long. And so that's some of the stuff that I think we have to think a little bit about. And the evidence, unfortunately, is not in favor of it. And so to do a procedure, I think we're having to start to think that we've got to have pretty high level evidence to put a child down. Now, surfactant replacement for meconium aspiration, I think you have to have pretty severe disease before I would consider it. I've been fortunate to be a part of some of the leucinactin studies of KL4, which is the synthetic surfactant studies, in which we did like 80 mL per kilo for lavage and those types of things. But we did it in kids that had mild disease. In other words, they had oxygen indexes of 7 to 10 was kind of the issue. That's pretty low. And that fluid does not carry oxygen. And so if it was mixed simple fluorocarbons or something like that that would carry oxygen out might feel a little bit more comfortable, that you could actually lavage that and keep their sats up and not cause them to go into fetal circulation or something like that would be a problem. And so if they're on the oscillator and they're heading towards ECMO, in our minds, we would often try a surfactant dose. We would not do a lavage dose, I would say, mainly because in our rabbit experiments and in some of our clinical experiences, it just didn't seem to help. Certainly, you seem to clean out a lot of things, but you also put the child through a huge stressor as well that we're not sure was beneficial.
But it works for non-suction.
Yeah.
It works.
Yeah, I think
And they
so.
are okay.
Yeah, I've seen it actually improve gastrostomy and those types of things. And I don't know if it just lubricates basically the meconium that was down there and disperses it differently. That's some of the theory, or the meconium itself was actually deactivating the surfactant. I'm not sure which one was happening in a lot of those kids, but given a kind of treatment dose of surfactant seems to be reasonable. Like I said, in the sicker kids, I'm not sure I would want to do it in a kid that I just intubated and is having a little bit of mild respiratory distress, or maybe even moderate, but the severe certainly.
Thank you.
When you talk about caffeine citrate and its role, it has any role in protection from bronchopulmonary dysplasia or the caffeine citrate. How did you talk about it? And I think in the guideline of surfactant that if we give caffeine citrate in premature, it could help in protection or shorten the period of respiratory distress.
I certainly like caffeine.
So,
I need more
what
of it every day. It seems like.
Okay.
I think it's something that certainly we think about a lot, especially when we're predicting the trajectory of the kid to get extubated. So in other words, if they got intubated for surfactant and they had a little bit of mild, moderate respiratory distress, and we're heading towards extubation, then we're quickly thinking about starting caffeine, and almost proactively before, because we used to wait until they started having apneas extubated. It's kind of too late a lot of times, and so we would start doing it if we think they're going to be a day or two from extubation starting.
Yeah, it got to be a standard of care, actually, in most U.S. NICUs, giving a loading dose of caffeine before extubation, and some give it. We talked, a couple days ago about Columbia Presbyterian Hospital and their outcomes. They give everybody caffeine. Everybody gets it, pretty much, when they come into the NICU. They don't wait until extubation. They do. Yeah, they don't wait until extubation. Everybody gets caffeine. They get a loading dose, and then they get a maintenance dose, and they stay on it until they're breathing on their own without devices for a significant period of time.
I've asked the same question in a meeting. There was Professor Bancalari and Professor Christian Speer from Germany. I told them why not to give caffeine immediately after intubation and ventilation. It's well known that caffeine delays diaphragmatic fatigue, and you have got a better contracting diaphragm. The baby is more ready to be extubated earlier and less days on ventilation. Professor Bancalari was with this issue, and Professor Christian Speer told there are no evidence, so I'm not going to do it.
Well, there's also some neurologic concerns too, from what I understand, and so that's why I think some people are a little bit concerned about just starting it right after intubation. In other words, they certainly see it as you're heading towards extubations, but I'm not sure. I haven't read the literature lately about that, but I know that I've been given excuses by some mentors of mine of we don't really know the neurologic effects of caffeine, theophylline, those types of things.
Yes, in the CAP trial, they have published the results, and those who received caffeine for facilitating extubation had a better neurological outcome at the age of 24 months, and this advantage was lost at the age of 5 years. It didn't persist. They did the CAP trial with almost 2,000 neonates including in this search, to search for this issue with the anti-adenosine effect of caffeine and the effect of this. They thought it would have a deleterious effect on the brain, and actually what I found, it was a positive effect rather than a bad effect.
Well, at least didn't hurt him at 5 years. Helped
Till
him
now.
out. Helped
Till
him.
now.
It helped him at, you know, at the beginning of
And
it.
everybody, I think all of us would like a 2-year-old to be a little bit more mature. That would be
One more question?
We meet a frequent problem with the small premies. Why after ventilation or even with CPAP, especially those less than 1 kilo. Whenever they are relieved from ventilation and we are reaching full intake, we have a problem of gastrostomy reflux. Commonly, it's a common problem, we meet it, usually with the small ones, and we start nasojejunal feeding. Of course, several steps before going to nasojejunal feeding. Usually, we stay a lot of time over this nasojejunal feeding, and maybe sometimes we also require nasal fundoplication because all this time we have refluxing baby and the chest is bad. Now, my first question is, of course, the nasal with gastrostomy, it solves the problem transiently. However, we have also seen a patient who died later on with adhesive intestinal obstruction. And it was for us a very big shock because this baby stayed in our unit, it was 27 weeks, and stayed in our unit, for example, around 4 months. And he was going out without intracranial hemorrhage and he was very good. Actually, my question is, do you meet also this problem as frequent as we do? And are there any precautions you take so that not to meet this problem or to confront this problem? Maybe we have something wrong in our practice.
So this is a very common problem that we find, especially as in our current unit, the current unit that I'm in, we don't get the infants until they're several months old and have had some problems. And oftentimes they're transferred over to us for a second opinion for reflux. Oftentimes they're transferred to us for another reason, and we find that they have gastric reflux because they were silently refluxing, and oftentimes you don't know because they're premature, so you contribute their desaturations and bradycardic events that occur with their chronic lung disease or developing chronic lung disease and whatnot. So what we started doing on several different babies was doing trials of post-pyloric feeds and pushing the feeding tube down below the pylorus. Yeah, and we monitor them and really having the nurses really closely monitor a log to take a look at if they desaturated, how far did they go, were they bradycardic, and what events surrounded before that started. Was it around feeding times, or was it out of the blue? Was it when they were trying to poop? Was it when, what was happening? So we can get a better idea as to the circumstances. And then pulled them back to gastric feeds and did the same trial for the same periods of time and got the same amount of data and compared it. And some infants we found, it didn't matter where we were feeding them, they still had problems. So doing nasal fundoplication wasn't necessarily going to help them. And we tried some other treatment options. And then we're currently in the process of doing an N of 1 trial or of several infants where we're actually collecting really good data, and it doesn't require somebody to be there to write things down, where we're getting streaming data from blinded pulse oximetry for apnea and bradycardia events, doing post-pyloric feeds and gastric feeds to see if that is an appropriate diagnostic tool that we can do at the bedside to determine if they actually do need a nasal fundoplication. And we know from our discussions that we have weekly with all of our chronic lung disease patients that we've been able to determine whether or not they need a Nissen in about 50 to 60% of our patients, but a good 40% of them, they pretty much are the same regardless of what we do, and we're trying to figure out, calling GI and figuring out what other options we have for them, that they almost clearly have reflux symptoms, the retching, the arching of their back, particularly surrounding feeds, and what are some of our options. And a couple of those children, we did G-tubes, but we didn't do a nasal fundoplication because it didn't seem to be really warranted to put them through that surgery when there are some of those side effects to it. But currently, I don't know of any really good diagnostic tool that says do one or the other. hopefully we have 2 more patients who can enroll in that study, so we'll know whether or not it's a diagnostic tool or not. So.
Okay, I'd like to enlighten
about
about
the car seat test. I've seen it in Boston and Seattle. It's a sample test. I don't know why we don't have it here. Could you just give us a little idea about its importance before discharging, of course?
You guys are such crazy drivers. You keep the kid awake the whole time. So we don't need to test it out.
Before discharge, you do have a car seat test, yeah?
Yeah. Yeah.
Car seat test.
Yep. And so they're looking to make sure they're going to stay breathing.
How many of the attendees know what's car seat test?
No, we don't know.
One.
We have a person.
Yeah, I mean, it's kind of become the standard of practice, and I think most of the hospitals start seeing it as a liability, is that if we don't check these kids. Many of the car seats are not rated for these smaller kids, and so you have to make sure that you're aware of that, because if they try to put them in an inappropriate seat, in other words, they just buy one commercially off the shelf that fits both normal kids and bigger.
No, I mean before discharging your preemies from the NICU, it's a routine. I guess it's a
Yeah.
event also.
It's 100% of the time, because we're in the U.S. a very litigious society, so we do a lot of things because it just becomes routine. If we don't check, we're going to get sued later on. So it's 100%, and we do it within a week of discharge, so that we can determine if the car seat that the parents have is appropriate. Sometimes, especially in our premature kids, some of them need car beds, and we have those available because they can't sit that way. But oftentimes during the car seat challenges, and for those that don't know what it is, we just have the parents bring in the car seat, we put the baby in it, keep them monitored, and watch them for a period of time to make sure that they don't. We just use it. We just keep them on the regular monitor and make sure that so we have their heart rate, their respiratory rate, and their oxygen saturation to see if they have any apnea problems. And oftentimes, if they do have problems with obstruction, we're able to modify how the child is sitting in the car seat and teach the parents how to do that and what to look for to make sure that the airway stays open, they're not flopping around, and giving them the appropriate support. And every once in a while they need to go into a car bed, and they can't be in a car seat.
For how long?
30 minutes. Yeah. Sometimes we'll go longer if we suspect that there's a problem with that infant who will have periodic issues that doesn't always happen when you want them to happen, so we'll put the kid in longer. But there's no really good guidelines for that.
We certainly go longer, particularly like both of us are referral areas, and so if they have to be in the car seat for 2 hours to go home, for example, then we'll probably test them 2 hours, if that makes sense. But if they have an average 30-minute drive or something like that, which most of our patients do, then we just do a 30-minute test, but they may extend it sometimes a little bit longer just to make sure. And then, like Natalie said, sometimes we create little bumpers and those types of things to help position their airway if they have issues, or they tend to flop to one side or the other, and do that. And sometimes even our physical therapy and occupational therapy colleagues will help us find the appropriate bumpers and stuff that we need that are commercially available, so we don't have to make stuff a lot of times.
And part of the concern too is where the seatbelt part of it hits the babies. Just like those of us who are vertically challenged, when you get into a car, the seatbelt hits you right at the neck. So if you're actually in an accident, you can get a really bad neck injury. So same thing with the babies. If they're really small, they might need some modifications to where the seatbelt pieces are to really help. And there are certain brands, because the brands change all the time, and our nurses that do the discharge planning and the car seat challenges know this best. For some of our premature kids, they'll tell the parents these are the brands you should buy because we have better options to modify where the seat belts and everything are for it to work.
Okay. Thank you very much.
Any other questions?
Thank you very much, Brian. Thank you very much, Natalia. And now we come to Hero Baby session.